The Cancer Assist Show, hosted by Dr. Bill Evans and brought to you by the Cancer Assistance Program. Help when you really need it.
Well, welcome to the Cancer Assistant Program podcast, the Cancer Assist Show with Dr. Bill Evans, that's me, and we have a really interesting guest and topic this particular podcast. I think you're really going to find interesting. As you know, if you've listened to any prior podcasts, we generally have focused on topics like the new management of lung cancer or breast cancer, but this is going to apply to everyone who has received a diagnosis of cancer and to their caregivers who are giving support to them. So I'm really pleased to welcome Dr. Danielle Petricone-Westwood, who is a psychosocial oncologist, recently joined the staff of the Juravinski Cancer Center and brings a wealth of experience from work in this area from the Tom Baker Cancer Center in Calgary, Alberta. And so welcome, Danielle.
Thank you. It's wonderful to be here today.
Let's just start with a little conversation about you, how you ended up becoming a psychologist and with a focus on oncology.
Yes, absolutely. So I was one of the lucky ones when I was, I think, in grade 11, realized that the social sciences were for me. And so, and that was confirmed my first year of university. The intro to psych class, I loved psychology. I thought it was so interesting. So from there, I knew I wanted to study psychology, but I wasn't quite sure what part of it. But I did really like the interpersonal factors, right? How we respond to each other and all of those components. And so in my fourth year, during my honors thesis, I met Dr. Sophie Labelle, who ended up being both my honors thesis supervisor as well as my doctoral thesis supervisor, who studied cancer care, and I was interested in couples at the time. So my honors thesis was also with Dr. Sarah Beatty, who was studying couples where one member was receiving a bone marrow transplant for a blood or bone marrow cancer. And so from there, I thought it was interesting to see how these medical components, these medical experiences of going through something like a cancer has these really important psychological components to it, both for the patient as well as the caregiver. And we were looking at, for example, feelings of equity within a couple. So not only is the patient being cared for, but how are we caring for the caregiver as well? And so since then, I never looked back. I got to work at the Princess Margaret for a couple of years with a trial for patients with advanced cancer and how they were coping. And then went on back to the University of Ottawa to do my PhD, and there I studied partners of patients with ovarian cancer, because while I was at the Princess Margaret, we were recruiting many patients with ovarian cancer there, and often I would come across their partners, who often were husbands, and they said, well, what about us, right? You know, who's checking in on how we're doing? This is quite a bit, right? And so that's what motivated me to study how they're doing and to focus on them.
Very important, and I think often overlooked. As an oncologist, I know personally that when I went into a clinic room and there might have been a family member sitting there, my focus was still all on the patient, and rarely did I ask any questions about how the family member, be it a spouse or the mother, father, how they were coping with the illness that they were witnessing in their loved one. So it's terribly important that we focus more on that, and it's good that we're doing this podcast because maybe that elevates people's awareness of the importance of that. So you've had a wealth of experience already in doing research on it, and so what are the sort of themes that kind of the prominent themes that come out for first of all, with the cancer patients? What are the stressors that they're perceiving and living that you as a psychosocial oncologist can help them address?
Mm-hmm. Well, everyone, of course, is different, and everyone has different reactions. And of course, it's never easy to be told that you have a cancer diagnosis, but some people have a hard time near the beginning at the time of diagnosis, and many people have more difficulty around the time of survivorship, which we can talk to, and kind of how do I move forward. One major component that comes up is the fear of cancer occurrence. That's something that probably is the number one thing I will hear when patients come to see me, is that what if it comes back? What if it gets worse? What if I have a second diagnosis? And That's a very common reaction, very normal reaction, given that they're told that it could come back, right? We're never quite given the reassurance that it's totally done, no matter how low the stage, how, quote unquote simple, although I'm sure it's never simple, the treatment of their disease.
It's interesting that that's one of the commonest things you hear. I guess, again, from my experience, I'd say at the very, very beginning, often we give them a lot of information, a ton of information about what kind of cancer they have, the stage, the tests they'll need to go through, the treatment they'll need, the acute side effects. And it's kind of a big information dump and a bit overwhelming. And often we talk about people being like the deer in the headlights. It's just so much to absorb that they maybe don't absorb hardly any of it, and you have to kind of repeat it on subsequent visits quite a bit. When does the fear about recurrence, is that early on in the course, or is it after they're kind of wrapping up all the prescribed treatment and then they're starting to think, well, this could come back, and the doctor did mention that at the beginning?
Absolutely, that's a good question. So, as I said, it can happen at any point of the treatment trajectory, but it's especially common as they're nearing the end of treatment, because when we think about anxiety, anxiety is a very normal response that we have to threats. That's why we have anxiety. So it's quite adaptive. If we didn't have it, we might be worried that you may not come back for your follow-up appointments because you weren't worried about how this would go. So it's a very important emotion that we have. But while we're in treatment, we have that worry about what's going on with my cancer, but at least I'm doing something about it. This, chemotherapy and surgery, and radiation can be quite awful to go through physically, but in a way there's an assurance, well, I'm at least doing something about it. But then as soon as that treatment ends, you're left with just that anxiety about, well, this still could, in theory, come back. I've been told that I have to be careful, I have to attend to it. So that's when it's normal for that anxiety to not be managed anymore, because we're doing, that there's this actual intervention going on. Now we have to wait and see how this goes. And for a lot of people, that can be really difficult. Of course, you want to be doing everything we can to make sure it doesn't come back.
We'll talk about a few of those things in a moment, but I think that, again, from my experience, when patients are coming, say, every 3 weeks to get their treatment, that they feel like they got a connection to the experts who are going to look after them. And when they finally finish maybe a course of treatment and things look good, and then they're told to come back in 3 months, it's like, oh, all of a sudden, I don't have that connection there that I had to the oncologists who are saving my life, So it gets kind of scary, and actually it can take an extreme form. Like I once, when I was working in Ottawa, was touring a group of patients through the facility, and we were in the process of actually reducing the number of late follow-ups or long-term follow-ups. Some of these people were coming back every year, and I had this lady approach me. She was on 20 years of follow-up, 20 years of follow-up, and she said, "I hear they're going to stop us coming on an annual basis. That's terrible. I need to come." She needed that reassurance from the specialist. And it was so hard to cut them off. And I was so impressed how people feel this connection to the cancer center. It's like a lifeline that they need to still hang on to. So that's very hard to do, but it underscores the anxiety about being maybe cut loose from what they see as the experts who are able to keep them well.
Absolutely.
So we need to talk maybe about some of the ways that people can cope with that fear, and what are the practical things that people can do. And often it's things they can do for themselves, because it gives them more of a sense of being proactively engaged in their own health, as opposed to relying exclusively on things that the doctors tell them to do.
Absolutely. So the first place that I always encourage people to think about is what we call checking the facts as an intervention, as a skill that we use to cope. So go back to any notes you might have, what the doctor told you. Go back to any plans you might have of things the doctor needs you to look for and pay attention to. And if you aren't having any of those things, to even just name that perhaps this is worry, this is anxiety, to be able to distinguish between the two. Of course, contacting the doctor if there are concerns is okay. But if that's happening quite a bit, then they may also want to try some other strategies too. Sometimes it can be helpful just to talk about it with someone you trust, someone who can validate, or if you are supporting someone having this experience, just to normalize and to hear it out without necessarily negating their experience, because this is scary. And it's okay to feel that worry. So that's one piece I would also encourage, is to look at that. And of course, if you are having a hard time managing these worries, if you feel that they are interfering with your day, they're preventing you from enjoying your day-to-day, that might be a time to come see us in psychosocial oncology, where we have both group interventions and individual therapy, where we can support people and help to look at, where is your mind going, right? What's the scary part here? And usually what we do is we take a look at, what is that scariness? Where is your mind going? And what kinds of stories are you telling yourself? And once we do that, once we really put it on the table, we can take a look, and it helps us to reframe a little bit about those worst case scenarios that we're always finding ourselves in, that are hypothetical and probably quite unlikely. But
It seems like there's a power in just having an opportunity to talk about what's worrying you, right? Whether it's in a group setting or whether it's to, friends, neighbors, people you trust, or a psychosocial oncologist. And I don't quite understand what the power of is, but it does seem to be therapeutic in and of itself to have that conversation, right?
Yeah, so for one, there's something we say a lot in psychology, is you have to name it to tame it, in a way. So if those emotions are feeling out of control, if we can just name what's going on, if we're able to label it, put a name to it, it automatically will settle it a little bit. And sometimes with anxiety or fear of recurrence, it's actually not just fear that can be going on. Sometimes, even if we don't know what the future holds, there's the reality of everything you've gone through with the last however many months or years of having a cancer diagnosis. So it can be helpful even to name that it's sad that I have to think about cancer. It can be there can be loss, there can be grief there, and sometimes being able to distinguish those feelings, or even anger. Right? I think as a society, we sometimes say, oh, anger's not, it's not a kind of a valid feeling, or there might be something wrong with us for feeling angry. But how could you not be angry that you've gone through all this? There's a terrible injustice there. So naming it can sometimes, just putting words to your experience.
Just on the anger topic, I imagine that's probably more common in young people. Is it? It's because they feel like they're being robbed from a normal life that they can plan, and maybe they've already been making plans for their education, their marriage, children, careers, so on, all suddenly stopped by the diagnosis of cancer.
Absolutely, because I don't think anyone really plans for these things, or there's, right, that you never expected that you had to carve out 2 years of your life for a cancer treatment. So anger absolutely is another very valid emotion that we have that comes up when there's an obstacle in the way of us achieving a goal. And absolutely, as a young person, that it can be extremely angering. And it's important to name that anger. There's nothing wrong with you for being infuriated by this.
Totally understandable.
And even I would say, often sometimes we hear from patients who have just retired, and they were ready, they were excited, they had just retired, but then here comes this cancer diagnosis.
Boy, that resonates with me. I've seen so many patients in my career who were planning, as soon as they retired, to start traveling and to taking up hobbies they'd been putting off because their career had been very all-consuming, and then they get a diagnosis of cancer. And maybe it's an awful cancer like pancreatic cancer, and they've passed in 3 months, which has always underscored to me why it's important to live each day to the fullest, and to realize that life is uncertain. It becomes more uncertain, I think, when you have a diagnosis of cancer. And I think that's part of the problem, is living with that, learning to live with that uncertainty.
Yes, absolutely. Because, and I talk often to my patients about that, in theory, nobody really knows how long their lives will be. No one really knows what's going to happen, but cancer makes that a lot more real. And it's not the same as the hypothetical, right? We don't know what our lives will look like. So it can absolutely flip you upside down. It's not something we plan for, and it's normal to feel flipped upside down too.
But information certainly helps, and of course, with the issue of recurrence, there are cancers where the probabilities of recurrence are very low with current best treatments, and we're talking with the physician or going online and getting good information may provide reassurance that the risks are quite low, and therefore maybe have a better chance to put it in the back corner of your mind. I don't suppose you ever put it totally out of your mind. Unfortunately, there are other cancers where risk is high, and in those situations, it must be much more difficult to, to deal with that concern about the disease coming back, and perhaps having to go back through the kinds of treatments you've just had, particularly if they were particularly upsetting and produce side effects that were, unpleasant to go through. So but getting information, I guess, would be an important aspect for each patient to have to best cope with the fear.
To a certain extent, absolutely. Getting that information can very much be helpful, but I would always be careful when we're looking for information as a way of coping with that anxiety, where you find yourself on Google pretty much 5 times a day, or you're spending lots of, turning into a scientist, trying to understand everything and anything about these statistics, right? Because we have a belief that if I'm studying these things, if I'm really teasing it apart, somehow I'll be able to figure out what exactly is my percentage of risk, as opposed to being in a large population of, where we get these scientific data comes from large numbers of patients. So information can help to a certain extent. But again, when we also know that with the fear of recurrence, that there is no correlation with how intense that fear of recurrence is and your stage of disease. It doesn't necessarily have anything to do with how many treatments you've been through or the type of cancer you have. Some people have very curative cancers, and they still can be quite overwhelmed with that fear of recurrence. And everyone can be very different. And other people who have had a number of treatments, who maybe are not given quite as positive a prognosis, but are actually managing it okay. So again, it's
a spectrum of response, isn't it? And that rings true for my experience. I had a very interesting experience quite early in my career. I think it was just in training at Princess Margaret Hospital. And I saw an individual who had Hodgkin's disease treated, a young man, and he was told he'd have 10 years. And when I saw him, he was right at 10 years. And now he assumed that his life would end. It was almost like a thunderbolt would come down and strike him down any time now. And he was in a high state of anxiety because he'd been told he'd have 10 years. And he took it very concretely. When it was meant to be encouraging, prospects of long-term survival are good, you'll live 10 years. But he took it as that would be the end of his life, and was extremely anxious as a consequence. So it underscores, too, how doctors need to be careful about the words they use to patients, because the patients have trouble translating necessarily doctor speak into what might be real for them in their lives.
Yeah, and I think everyone is different in terms of what they do want to hear and what they don't want to hear. Some people really like numbers, some people really don't like numbers. So I think that it's important both for patients to ask the questions that they have, and also to communicate if they don't want to know something. That's okay too. It's actually really helpful to their team to know where are they at? How can I help them to feel better? Is it with more or with less information?
Yes, that's an extremely good point. And even sometimes patients will tell you they want to know, and then when you tell them, after constantly asking them, do you really want me to give a number? Because I really, I'm not God. I can't give you an exact number of how long you've got to live. And they keep pressing and pressing. And I've had this experience. And then you tell them, and then they become totally deflated and angry, and had one just walk away from treatment that might have been helpful because he was so upset by the information he had demanded. So it's so hard, I think, at times to gauge. So the message maybe to patients is really think carefully about what information you think will be helpful, and don't ask things that you don't really want to know about, I guess, because that probably works for a certain number of people, to just remain in a state, shall we say, of mild ignorance.
In a way, yeah, absolutely. And I think that perhaps even for this person that they got very upset to hear your answers, but perhaps it was still helpful for them. It helped them to make decisions for how they were living their lives, how you prioritize those things. And I'd say all reactions are reactions, and they're all okay, right? It's just we got to make sense of, okay, well, what's my body telling me then? If I'm pretty upset to hear this, what does that mean? How do I move forward with that?
So what I hear is there's a full spectrum of responses. They're all legitimate.
Yes.
And you get to see them all.
Absolutely. Yeah.
So we'll talk a little more about how you react to some of them in a few minutes. But we're going to take a break now and have a word about the Cancer Assistance Program that brings a variety of free services to cancer patients in the Hamilton region. And we'll be right back with Danielle Petricone-Westwood.
We'd like to take a moment to thank our generous supporters, the Hutton Family Fund and Banco Creative Studio, who make the Cancer Assist show possible. The COVID-19 pandemic has not stopped cancer. Instead, it has added to the isolation and challenges already faced by cancer patients and their families. The Cancer Assistance Program remains committed to providing free, essential support to cancer patients in our community, whether it be transportation and equipment loans, personal care and comfort items, to parking and practical education. With no sustainable government funding, we need your help so we can continue to be there for those who depend on CAP to stay safely at home. Individual and corporate support of signature events, third-party fundraising, and financial gifts are greatly needed. Visit cancerassist.ca to see how you can make a difference in the lives of cancer patients and their families.
We're back with Danielle Petricone-Westwood talking about risk of recurrence and how people react to it and strategies. And we were talking about some of the coping skills. We were talking a bit about when a person might be referred to counseling, and we want to drill into that a little more. But maybe to start off, I just want to share that as a physician and also a lung oncologist for much of my career, didn't really identify the psychological impacts of cancer on my patients very well, or on the caregivers for that matter. Partly that's on me, but I think it's partly too that patients come into the clinic probably putting on their best face. And when you ask them, it's almost a reflex, how are you doing? Unless there's something really bad going on, there's a brand new terrible pain or something, they tend to say, oh, I'm doing okay, doc. And then they wait for you to tell them whether the scan shows a smaller size of their cancer. And as a result, I think we missed the boat a lot. And I was really surprised when we started getting data from patients who completed the Edmonton Symptom Assessment Scale, and we were tracking their symptoms of anxiety and depression, just how common these symptoms are and how severe they are. And they would clearly benefit from having interventions to help them deal with either their anxiety or their depression. And so I think it's a bit of a shout out to patients to don't put on the brave face. If you're having a difficult time coping, if you're very anxious about things or you're feeling terribly down, you have a sort of paralyzing depression, don't hide it from your oncologist. Complete those ESAS assessments when you come into the cancer center each time, and talk to the nursing staff as well, and get referrals to Danielle or others like Danielle in the cancer center. So, but do you see that sort of masking of symptoms, the psychological symptoms in your practice? Yeah.
Absolutely, and sometimes we do it without realizing that we're doing it. Sometimes they do it because, in a way, they want to make sure that they're not taking up too much of their oncologist's time. They want to make sure they get their questions about the physical parts of the cancer going on, and maybe they don't know that it'll be helpful. I also think that a big part can sometimes be the social norms we have if we're of a certain demographic, right? Again, having studied male caregivers, that they tend to just say, oh, I'm okay, don't worry about me, worry about my wife. That there's a kind of a stereotype that men can't be upset about these things or worried about these things necessarily. And that's, of course, a sweeping generalization. But sometimes these little nuances can get in the way when we're talking to our team. But absolutely, if the oncologist doesn't know that this is going on, then they can't necessarily get you connected to the supports to, for example, our very specialized team. That's part of the Juravinski for this reason. Mm-hmm.
I guess, too, there's another reason that patients maybe don't want to take the time of the oncologist because they've been sitting in a waiting room perhaps for several hours, and they know there are a lot of other people sitting out there. So if I start telling the doctor about, how I'm just staying in bed, I'm not eating very much, I don't have any motivation to do anything, they're just taking the physician's time from seeing those other people who are waiting, and hence needs don't get met. I think that's part of it. So let's say the patient does indicate their need and they're profoundly anxious. What determines whether a person gets to see a psychosocial oncologist individually or in a group setting? How do we sort those things out to be the best benefit for the patient?
Absolutely. So there's lots of factors. At the Juravinski, how this works is our team gets the referral, and then we triage them, because we'll get referrals also for practical things with our social work team. So we'll triage it either to social work or to our mental health team. And then from there, we typically will do an assessment on any patients who are referred to us. So they'll come in, they might meet with me or one of my colleagues in psychiatry, and that's where we assess what's going on. And we can make that distinguish for them, the distinction for them rather, whether they should be seen by a psychologist or a psychiatrist, or whether they would benefit from group. And that's partially also up to the patient. Some people are very happy, and it's very healing to hear other people going through the same thing, just to, again, normalize, as we were earlier, how common it is to be struggling with this, and how it's okay to have a hard time. Sometimes all we need to hear is that other people are going through the same thing. But some people are a bit more private, a bit prefer to kind of have this one-on-one, or perhaps they have a history of mental health concerns that might have been activated a little bit or worsened a little bit with the diagnosis, in which case we want them to have something a bit more tailored, which is where they might see a clinical psychologist, for example. And so that would be with myself or my colleague, Dr. Zhang, when she's back. But that's typically kind of the distinction, or perhaps even if medication might be helpful for a lot of people. It can be incredibly helpful to start some forms of medication. And so that's where our psychiatry team also can be really helpful and a great support. But sometimes also, again, coming back to just needing to hear from other people what's going on. We may also encourage that they try some of the support organizations who host groups, for example, like Wellspring or Wellwood, and I believe you've had them on the show as well. So those sometimes are just what some patients need to feel heard and to be, to feel that they're getting the support that they need.
And as part of your role to make them aware of these resources, because most people, when they get a diagnosis of cancer, they don't know that there's a support group for prostate cancer or for ovarian cancer or for young people with cancer. It's a whole new universe that they're entering, and can you help them get directed to something maybe more specific to their needs? Because imagine if I'm an older man with prostate cancer, I don't want to sit in a group with young women with breast cancer, because I'm not going to connect with the same kinds of issues they're experiencing. Probably want to talk to a bunch of other old guys with prostate cancer and see how they're managing and what their doctors are telling them and so on. Is that how it generally works?
Absolutely. If we're aware of them, we're happy to share them. So, even there's Ovarian Cancer Canada or Leukemia Lymphoma Society. Off the top of my head, even the Canadian Cancer Society also has a number of groups. So definitely, if they come to see us and we think, you don't need to necessarily have individual therapy, that if we believe they might benefit from one of these organizations, many that have been incredibly good at transitioning to being online during this pandemic, we often might say, why don't you try that first, right? And we always want to touch base with them, and if they might try them and it's not quite enough, then we can reassess. We can definitely try to figure out what's best for the patients and how we can best support them.
You just raised an interesting topic, which is the impact of the pandemic and a lot of virtual care. And how has that impacted you in delivering supports to individual patients?
Yeah, most of my practice now is virtual, which actually prior to the pandemic, I still did quite a bit of phone therapy, because it would be tough for patients to travel into the clinic to get their session. So we thankfully already had that experience. but we have transitioned mostly to Zoom. Now we are welcoming patients back into the clinic. We still have to wear masks and sit apart, but if they prefer that, if they're comfortable with that, we are transitioning back to the in-person. But absolutely, most of our practice has been through Zoom. And prior to the pandemic, in psychology as a field, in psychosocial oncology, we were working to do all these trials to see, well, can we do virtual care? How does it work? And I guess that's a huge silver lining of all this, is that it catapulted us into just figuring it out.
And you had to do it.
Yes, absolutely.
I actually heard from some that they felt that patients were more comfortable with the virtual meetings. It was almost as though they could reveal more of themselves to a screen than sitting in a room with a person.
Absolutely. I think that's pretty common, and I think especially because for a lot of patients, they haven't ever had therapy before. They perhaps haven't needed it in the past. And so it might be a little uncomfortable. We're working really hard to dismantle the stigma of mental health, but it still exists. So sometimes even to be able to use the method, that just feels more comfortable. I'm glad that we have phone, virtual, in person, whatever works best, but absolutely. And it also, just even from a practical standpoint, you can just hop on,
and you don't have to get in your car and drive through a snowstorm to get to see someone at the cancer center, all those very practical issues. Now, we touched a little bit on caregivers, but again, I don't want to leave them out of this conversation because it's so easy to just focus on the patient needs. And there's groups for patients and opportunities for patients to meet with someone from the social work department and so on. What about the caregivers? How do we even identify them? We don't have a screening tool at the front door like we have for the patients. And who's finding out that they're having a difficult time and helping them?
Absolutely. Well, I think for one, that would be a great start, is if we started to do the ESAS with the caregivers, to have a check-in with them.
That idea just came to me now. Yes. We'll have to promote that with Cancer Care Ontario or the Juravinski Cancer Center.
Yes, absolutely. So, I think it is very important to check in on the caregivers. And sometimes it's tough, I have to say, if they're both in the room together. Sometimes they're comfortable to be forthcoming, but sometimes the caregiver doesn't want to worry the patient, of course, of how they're doing. We have something, concept that I'm sure you've seen, which is called protective buffering, where both the patient and the caregiver might be really having a hard time, really struggling, but they want to protect the other person with what they're going through, so they end up kind of both hiding what's going on.
Works both ways, doesn't it?
Absolutely.
Each trying to protect the other.
Absolutely. Both trying to kind of not burden the other with what's going on, and which can actually contribute to some feelings of loneliness, which we hear about a lot with people going through cancer, because they aren't sharing. So I do think that I believe that cancer care in general, I think that we have to improve how we're checking in on these caregivers. And the reality is, in my research, we found that although, of course, psychotherapy can be helpful to them, a lot of times they also just need practical help. They need support doing all the things that they're doing. They need the team to say, what are your questions? What do you need help with? What's some information perhaps that you need that you don't have? Or are there some ways we can facilitate your job, right? Because these caregivers do a tremendous amount of the work, contributing to treatment. And I believe this was a stat about caregivers in general, not just in cancer care, but they can end up doing almost 80% of the care, right? And
that's particularly tough when the patient's becoming more ill and they're taking on all the home care. And these days, it seems that we can't deliver enough home care to support all the needs that are out there. And so the caregiver ends up doing a lot of things that are physically demanding, unpleasant to do, and as well as being emotionally demanding. I did see something in my experience too that I wanted to ask you about, and that's the amount of maybe marital discord that results sometimes because of the interaction around an illness. And what I have in mind is an observation of a couple where the wife was trying to be very, very helpful, but the man was trying to be that strong, I can look after myself even though he's the one with cancer and not doing very well. And the dynamic became just hostile because the women's efforts to be helpful, the nurturing part of women, ran headlong into the kind of, I'm a tough guy and I can manage this male attitude. And it was the friction I saw in the clinic was extraordinary. I could hardly imagine what it must have been like at home. And is that common, or was that a rare encounter?
Just like with an individual, a patient, or the family members, just as much as you don't plan for a cancer diagnosis to come along and to really affect your well-being, the same goes for couples. You don't typically plan for a serious illness or diagnosis to come into play. And just like it can for individuals, it can turn a couple upside down. It's a whole new stressor to have to navigate. And you can imagine that both parties are pretty scared about this. They're both really worried about what's going to happen. We know fear of recurrence is absolutely very prevalent in caregivers as well, right? Worrying about what happens if this comes back. So it's very normal. And just as with individuals, there are couples therapists who specialize in cancer care. Fortunately, sometimes it might be most accessible through private practice, but we are happy to help couples to navigate in Juravinski and get them pointed to the right supports to make sure that they can learn how do we call it how do we do our tango, how do we interact with each other, right? How do we get through this together? And I think the important thing is to remember with couples is that it may feel that it's me versus you a lot of times, that we're really arguing or really disagreeing, but the truth is it's us versus this cancer. It's us versus the challenges that we're facing, and how do we come together as a team, right? And sometimes talking about the tough stuff too, right? Because that protective buffering we know can result in lower marital satisfaction, feelings of loneliness. It can be really tough to talk about some of these hard things, but also might be very validating to share and to speak with one another about how hard this is, and to kind of reconnect in that way.
Yeah, I can only imagine how difficult it is for many couples to deal with it, but I must say that one occurrence from, again, my practice from the past really stuck with me, just the level of friction that occurred around the diagnosis. And again, being aware of what is available that could be helpful. And I think that's part of what we're trying to do through these podcasts, to make people aware that these things happen, these kinds of emotions occur, these kinds of frictions can happen. There are ways of addressing it, and there are people who can help, and you need to reach out to get that help. If you just keep having the friction, you're not getting anywhere. You need to have the benefit of the resources that are available in our community. One of the things we wanted to just briefly touch on too was the whole notion of survivorship plans, because that's something else that when you reach the end of your treatment and you have that feeling of maybe being cut off from the cancer center, that there's actually a transition to something that resembles normal life, but still has the periodic checkups. And that can be done often very well by one's own family physician. But family physicians aren't specialists in cancer, so they need to have a written plan. The patient needs to have a written plan that says, okay, every 3 months you're going to have these tests done, and blood work, scans, whatever. And if anything abnormal shows up, we'll see you back at the cancer center promptly. That must go a long way to giving comfort and reassurance and reduce some of the anxiety of separating from the specialist at the cancer center.
Mm-hmm. It can. I think knowing that there's a plan in place can be very relieving. I think, as you mentioned, some people do still want, it's hard to not be seen by the oncologist though, right? Because that's where they know they're the specialist. So many, these patients are very bright. They really know that this is where I'm going to get the best answers. So, and absolutely, the survivorship care plans are meant to make sure that the family physician is equipped, and I think it's fair to share your concerns with your family physicians, right? To just like we do with the oncologist, that if you're a little worried, if you worry that they might, if this isn't enough, right, to address those questions. Sometimes having a conversation with them might be helpful. And I even wonder for you, Dr. Evans, what you would say to a patient who says, well, I'm being transitioned back to my family doctor. Is that going to be enough follow-up, right? What you might say to them and give them the reassurance that even the oncologists trust these family doctors to be taking over here.
Well, in truth, I think for years and years and years, oncologists didn't trust the family doctors, and that's why they kept the patients, for 20 years of follow-up in the cancer centers. But it becomes impractical. We don't have the physical space and time and enough resources to be following up people and seeing all the new patients. So we had to figure out how to transition safely. But that means not only supporting the patient, but supporting the family doctor with information about what they need to do. And I think the vast majority of family doctors are prepared to pick up the care if they're told, this is what you need to do. Follow this, and we're here. If there's something that goes wrong, this is the number to call, and we'll get the patient back in and seen so that they don't feel frustrated trying to, jump over barriers to get their patient re-referred into the cancer system. So yeah, I think there is a whole trust issue, both with who the patient trusts, but often patients have trusted their family doctors for years and have had those conversations about the challenges of bringing up their kids, the stressors they had then, and their depressive episode when so-and-so died in the past. And so the family doctor knows all of that and can be supported during the survivorship period equally well, and it may be a better resource than trying to get supports within the cancer center with all the distractions of many patients and the tyranny of the urgent of getting people on treatment and assessed. Just as we get towards the end, maybe some of the practical things, the practical messages to both patients and care providers about this fear of recurrence, kind of the key things to think about if you're out there now listening to this podcast and you have a diagnosis of cancer. What are the practical things to keep in mind that are important so that you aren't overwhelmed by anxiety or pulled down by depression?
Mm-hmm. Absolutely. So I think the really important thing is, for one, to normalize it. I know I'm probably a bit of a broken record now, but it's so common and it's so normal, and it doesn't mean, some people really worry that their mental health is is not well because they do find themselves thinking about this, and they wouldn't consider themselves to be worriers, so to speak, before that. So to normalize it, right? I think to recognize that there could well be anxiety and fear, but there's also a whole bunch of other feelings that could be coming up. So just taking time to attend to what else might be going on. Am I grieving? Am I angry, right? And are there other things I'm worried about, And I think that those are some important practical things. And then, of course, if those things aren't working, then talk to your doctor about it. Absolutely. You can even call psychosocial oncology to self-refer as well. Even if you're not necessarily a patient at the Juravinski, you can usually self-refer to get some support. Most major cancer centers have some sort of psychologist or psychiatry team on staff now. So those are important things, and it's okay not to know, right? It's always confusing. So even if it's helpful just to have a chat, come in and chat with someone who specializes in psychosocial oncology, and to give them their opinion on how they're doing. That's what we're here for. Absolutely.
So I hear in that one of the key things is for patients and caregivers to be just open in their communication with the care providers about how they're doing. Not disguise it, not put it under wraps and put on that brave front in the clinic that maybe they think they should put on, but to actually just communicate how they're feeling so that they can get plugged into the resources that would be helpful.
Absolutely. And it's okay if it's too tough to talk to family members about this, although I know we were talking about the importance of it, but sometimes it is too tough, and that's okay, right? But definitely talking to your care team. Absolutely.
Well, I want to thank you very much for sharing your knowledge and your time with us today to talk about what's a very important issue for cancer patients and care providers, and one that we really speak about. So I'm glad we had a chance to do this podcast today, and hopefully listeners will find it helpful as they navigate a cancer journey. So once again, my thanks to Dr. Danielle Petricone-Westwood.
Thank you. Thank you for having me. It's been wonderful to chat. Take care.
And I hope you enjoyed this podcast, and we'll tune in again the next month on another podcast from the Cancer Assistance Program.
This has been the Cancer Assist Show, brought to you by the Cancer Assistance Program. Thanks for listening.